Hello, my friend. Welcome to my show, Chronicles of a Learner RN, and thank you for listening. My name is Ratika, and I'm a registered nurse working out of Melbourne, bringing my experiences and learnings to a wider audience. Today, we'll be talking about pulmonary embolisms and DVTs. As a disclaimer, I won't be providing any personalized information. All names, numbers, and results will be altered to protect the privacy of the patients these stories are derived from. So today's episode is a bit of a continuation of the last episode in terms of ailments, I guess is a good word for it. Last episode, we discussed my new first arrest, and the suspected cause of death was pulmonary embolism, although this will never be confirmed or denied. I just want to put in as an additional point of note, pulmonary embolism, I didn't talk about this last week. Pulmonary embolism is actually one of the 4 H's and 4 T's. It comes under T, thrombosis. But if we want to be picky, she had elements of hypoxia and hypovolemia, which are both H's too. But the thought is that these were byproducts of the pulmonary embolism. For clarity as well, for the rest of the episode, I won't be saying pulmonary embolism anymore because that I feel like is a bit of a mouthful. I'll be saying PE because it's, easier. Please don't confuse this for pleural effusions. They are very, very different things. We can go into pleural effusions if you want another day. Alrighty then, let's begin. Today we've actually got 2 case studies, both very similar. Both happened actually within 1 or 2 hours of each other, and both were not my patient. Therefore, I have extremely limited information and can only talk on my perspective of what limited information I knew. So this does mean that I could be missing vital contextual information, but I guess you and I will just never know. So let's give our patients names. Let's see. I'm not feeling particularly inspired today. We'll go Marcus and Marcus number 2. Inventive, I know. Basically, all I can say about both Marcus and Marcus number 2 is that they were both walk-ins, so they weren't transported by ambulance. Well, at least I think they didn't. Both had dusky limbs with no pulses, and they were both code strokes to our stroke centre. And both of these cases happened on the same morning, probably within 2 hours of each other. So we'll go into Marcus number 1 first. Marcus number 1 can give us good insight into DVTs. So Marcus's dusky limb was the arm. They had an altered sensation. I think they woke up, then it was like heavy. They had no radial pulse, and it looked, I used the word dusky before. What does dusky mean? It looks grey, mottled, and you just look at it and you know, there's no blood flow going to that hand. But this was their entire arm. The thing that got Marcus code stroked was during the assessment, they began to experience a facial droop, slurred speech, new onset confusion, and were exhibiting signs of, a stroke. Those that have listened to my episode on hemorrhages would be familiar with the fast symptoms of a stroke. The facial droop. You know what? I can't remember off the top of my head. We're just going to skip that part. I'm not really sure what happened to Marcus after they left our ED. I actually really hope they're doing well now. I never met Marcus in person. This was just a sort of story from the bedside nurse. So going into DVTs. DVTs are deep vein thromboses, or thrombosis is a singular. A thrombus is a stationary blood clot that is formed within the blood vessel. In comparison, an embolus is a blood clot that once formed begins to travel within the bloodstream. And when an embolus gets stuck, it's called an embolism. DVTs can form anywhere, but they are very, very common in the lower legs. Risk factors are quite vast, and they include being stationary for a prolonged period of time, such as, say, on a long drive or like an overseas plane journey where you're stuck on a plane for 13, 14 hours. Also, being bedbound is a great way to be stationary too. This is why when people come in with chest pain, we also tend to check their calves. If you've got a DVT, the limb usually becomes sore, swollen, tender on palpation, and usually DVTs are not life-threatening. The treatment, though, is just getting put on anticoagulation until repeat scans show that the clot has dissolved. Then you cease anticoagulation and start mitigating risk factors. There are also many clotting conditions that would increase someone's risk of developing DVTs and PEs. One particular one that's very pertinent to Marcus number 2 is factor V Leiden. Now, this would make more sense if you guys knew about the coagulation cascade. But do I want to delve into the coagulation cascade today? Not particularly. So maybe another day. Actually, we could talk about trauma one day, the diamond of death. That would link in well to the coagulation cascade. Yeah, we'll do that, because I don't want to overload you guys either. Anyway, I'm rambling. Let's continue. So, Marcus number 2 had factor V Leiden. This genetic mutation makes people more susceptible to forming blood clots. So, Marcus number 2 was shipped out after Marcus, hence being Marcus number 2. They came in after being, I think, bedbound for about 6-7 days with yet another dusky limb. Bedside ultrasound showed that they had an occluding DVT in their leg, I think. Obviously, because it was dusky and had no pedal pulse. But then a subsequent, and I think he, I don't know. I think they were also hypoxic, tachycardic, and tachypneic. I think when I went to go see them to help set up the heparin infusion, they were on a non-rebreather, so obviously very hypoxic. But yeah, I think they went for a CTPA, and it showed bilateral submassive PEs, or bilateral means they're in both lungs, and submassive is one step away from massive. But I think that got recategorized to massive later on. They were started on a heparin infusion. Usually with heparin, we give a bolus dose first and then start an infusion. Infusions are pre-made for us to mitigate the risk of sort of making it up wrong, and because it's a very delicate drug that you titrate to what's called APTT, which is the time to clotting. So in the coagulation studies, they actually I don't know how they do it, but they time how long it takes the blood to clot. When that's too long, we turn down the heparin. When it's too short, we turn up the heparin, if you get what I mean. And there's this time range where we like it to be for maximal therapeutic effect. But in Marcus number 2's case, they had already had a dose of therapeutic clexane. So we didn't need to give the bolus dose of heparin. Unfortunately for us, we didn't actually have any heparin infusion bags in Impress, so we had to order it from pharmacy. But that was my only interaction, helping the bedside nurse and getting the heparin infusion started. I did ask the ANUM, should we move them to resus? And they were like, we'll see. And then less than 10 minutes later, they were on their way, lights and sirens. But I later learnt that they actually had a code stroke on them as well, Marcus number 2, after another occluding clot was found in the carotid artery. I'm not too sure what happened after that. Didn't really want to delve into it because obviously they weren't my patient, and that is a very big breach of privacy. So that's really all I have for Marcus number 2. I'm not sure what happened and where they are now. I also hope, just like with Marcus number 1, I just hope that they're doing well, better. Anyway, so let's delve into PEs. There are 3 methods to finding blood clots. Usually ultrasound Doppler scans are used on limbs to see blood flow. We've actually got a mini version of this in the ED. We use it to find pedal pulses. You put the gel on and you put the probe where you think the pedal pulse is, and if you find a pulse, you'll be able to hear it. It'll go whoosh, whoosh. Sometimes very loudly if the last person to use it was a bit deaf or the pulse was a bit weak. You can change the volume, but it does get quite loud. But the main imaging technique, sorry, I'm rambling a lot in this episode. I'm very sorry, guys. But the main imaging technique used to find PEs is actually called a CT pulmonary angiogram. I mentioned it briefly in the last episode, but I didn't go into detail. CTs take sliced 2D images of your body, if you think about them slicing it up into little pieces, and then the software puts all these sliced images together to make a slideshow going down the body. So say if we wanted to CT your brain, it would take sliced images of your brain, put them all together, and we'd have like a top-down view and a sideways view and an every-way view of your entire brain. And we can go slice by slice to see where, so sort of like the bleeding may be, or where areas of ischemia may be. It's very, very useful. So in a CTPA, the pulmonary angiogram, if you've forgotten, contrast dye is injected into the vein. It then travels to the heart and gets pumped back out, with the goal being to see the veins in the lungs light up with contrast. Because obviously it has to go into the lungs and back out, because that's how the heart works. Areas that aren't lit up are where the clots are, because if you think about it, if there's a clot blocking the vessel, blood and said dye cannot get through. I feel like it's a very, very simplified way of explaining a CTPA. I'm sure there's a lot more effort and thought that goes into it, but we're not going to delve into that today. But one point to keep in mind is that contrast dye is actually nephrotoxic. Nephro meaning kidneys, and toxic meaning, well, toxic. So yes, it is toxic to the kidneys. Therefore, people with poor kidney function often cannot have CTPAs. That's when we segue to VQ scans. This is an alternate to CTPAs. I can't remember if I've mentioned VQ mismatches previously, but we'll go over it again quickly. VQ stands for the ventilation, V, and perfusion, Q, mismatch. Don't ask me why perfusion is a Q. Anyway, VQ is a ratio, but the ratio isn't used, like the ratio itself isn't used very much. It's now used more to highlight where the issue lies. So if there's adequate blood flow to the lungs, but gas can't exchange for a number of reasons we are very familiar with, like exudate from pneumonia or fluid from APO, etc., that is a yes. I'm going to assume you said ventilation. If you did, congratulations. It's a ventilation problem. If gas is there and it wants to exchange, but there's simply no blood in the capillaries to diffuse said oxygen and carbon dioxide, well then that is well, you have to get this one right because there's only two options. It is a perfusion problem, i.e. blood clots. Look how we've done a full circle. So therefore, a VQ scan looks at perfusion and ventilation. But how does it do that? So a patient presumably stands in a room, breathes airborne radioactive particles. Then the scan begins. Using specialized camera equipment, obviously it's not like we've got X-ray vision, the lungs are basically videoed, and you basically watch and see all of the alveoli light up as the air goes in. That's about as far as my knowledge on VQ scans go. I'm very much not an expert. I've never watched one myself. I can't interpret the scans, but look it up. You look at the lungs and they look all fuzzy. That's about as much as I know on VQ scans. They're very useful for people that can't have CTPAs. But obviously CTPA is the sort of gold standard of PE finding scans. So symptoms to think about when ruling out PEs include chest pain. And when you're sitting in triage, most chest pains become a Cat 2, but sometimes they sound really, really pleuritic. So they're like worsening on deep breathing or shortness of breath on exertion associated with the chest pain. That sort of points you in the direction of PE. But you can have, like I said, chest pain, shortness of breath on exertion, tachypnea, which is increased rest rate, tachycardia, increased heart rate, hemoptysis, which is coughing up blood, new cough, and hypoxia if it's advanced. This is why, as I mentioned before, people coming in with chest pain that doesn't really quite sound cardiac in nature, we ask about your legs. So next time, if you think, oh, why are they talking about my legs when my chest is the issue? That's why. Treatment for PEs pretty much is also anticoagulation. It actually previously was also strict bed rest, but recent evidence has suggested that the reason for bed rests was that so PEs wouldn't dislodge and become fatal. But it is said that there was limited evidence to essentially prove the risk. And it's said that anticoagulation is sort of just as effective and allows for a more gradual return to movement. So if people say bed rest is a pivotal part of PE management, their evidence may be a little outdated, just a little bit. And I say that because I myself thought that bed rest was still up-to-date evidence, but upon researching for this podcast, I found out that it wasn't. So I guess you learn something new every day. People are advised to re-present if the symptoms get worse. Sometimes they get discharged on anticoagulation, but better yet, a lot of people are admitted for strict observation and management. Now, this is all fine and dandy, but people have PEs and live all the time. So what's so dangerous? Well, with confirmation of PEs, and often as a precaution for anyone presenting with chest pain anyway, a troponin is done. Raised troponin and maybe even ECG changes can indicate heart strain. So if we think about it, the blockage in the lung is going to cause resistance or afterload back into the heart. Now, the right ventricle needs to pump against this added resistance, which leads to enlargement and dysfunction. This can be seen on ECGs through a right axis deviation and also ST depression or T-wave inversion in leads V1 to 4 and inferior leads, with lead 3 being the most sort of rightwards facing lead. So that's where you'll see the biggest sort of change. Now, there are many ways PEs can cause death. One of them being that the clot dislodges, moves to the brain, causes a stroke, but the other one being the ongoing right heart strain, right ventricular dysfunction, and eventual shock. Basically, I guess it's a cascade, really. You've got pulmonary hypertension, so you've got high pressures going into the lungs because of the resistance. Then that resistance backtracks back to the right ventricle, where you get hypertrophy, enlargement, and dysfunction. Then this eventually makes it back to the left ventricle, where it becomes compressed because of the right ventricular enlargement. Cardiac output decreases, and therefore preload decreases. Therefore, you get a hypovolemic shock, really. Therefore, the H for hypovolemia links in directly with the T for thrombosis. But the reason I think that there's a separate H for hypovolemia is more for people with like severe blood loss, so like a trauma or stuff like that. Whereas the T for thrombosis in this sort of situation works perfectly fine in my opinion. So that's really it for pulmonary embolisms. I know it's not really as sort of, what's the word? I wouldn't say not well researched. It's just a very nuanced topic that I only really know not the basics, but sort of an average amount of information on. I don't know, heaps and heaps of information on PEs. I think if you were a nurse in the emergency department, or even on a ward, or even just an average person, just keeping an eye out for symptoms, feel like this information right here is enough to get by. Now, I'm not going to call myself an expert because I'm definitely not. And that is not the aim of this podcast. It's not to give expert advice. This is simply what I am learning, and I am just relaying my learnings. So I suggest that if you find pulmonary embolisms a very interesting topic, which it is, and sort of the cascades that come about, you've got your ECG changes, your acute right heart failure and how that affects the rest of the body, how the thrombosis sort of forms, like I said, the coagulation cascade, and how there are many different genetic sort of deficiencies that cause people to either not clot enough or clot too much, such as factor V Leiden, and how the factors, vitamin K, and all these other medications sort of help treat clots, create clots, dissolve clots, help the factors work better, help the cascade work more efficiently. This is all very interesting information, and I suggest that you go and look it up yourself. Now, I will go into the coagulation cascade when I do an episode on trauma. I just have not yet had a trauma patient, but I have learned a lot about the coagulation cascade and the diamond of death and hypocalcemia, hypothermia, and how that all sort of is interwoven into a recipe, for death, which is why it's called the diamond of death. So keep an ear out for that episode. But in the meantime, this wraps up this episode of my show, Chronicles of a Learner RN. I certainly have learnt a lot, and I hope you have too. I have a plethora of cases and learning experiences I'm excited to share with those of you that are willing to listen. If you enjoy what I do, what I say, and what I can bring to the table, then please comment, rate, subscribe to the podcast. It means a lot. Thank you, and see you next time.